case of an 87-year-old woman presented with worsening mobility. Regarding differential diagnosis, make a quick list of possible causes of a given presenting complaint, and ask questions to rule in, or rule out, the possible differentials, as in this case, urinary tract infection, drug side effects, pneumonia, and stroke, are the top differentials in our list. Here, we are discussing relevant questions to take a brief history, keeping ourselves structured within a given time frame. Now, we ask detailed questions using the mnemonics ODPARA. Onset. How did it start? Did it come on suddenly, or gradually? Duration. For how long is it present? Progression. Since the start of symptoms, is it getting better, or worse, or staying the same? Is it the first time, or were there previous episodes? Aggravating factor. Have you noticed what makes it worse? Relieving factor. Have you noticed what makes it better? Associated symptoms. Independence, or dependence, and identify carer role. Mobility issues, Parkinsonism, stroke, etc. Whether patient can move unaided, or with support of stick, or frame. Any falls recently? Housing, important for safe discharge planning. Moreover, ask for any precipitant like infection, urinary symptoms, by asking about dysuria, frequency and incontinence, pneumonia, by asking about cough and breathlessness. Ask for drug changes recently, benzodiazepines, diuretics, and BP medication for postural hypotension, antipsychotic, risk for extrapyramidal side effects, steroids, causing proximal myopathy, anti-Parkinsonian drug changes, systemic inquiry, sites of pain. Furthermore, discuss legal aspects, advance directives or living wills, power of attorney, DNAR and other treatments. At this point, we have ruled out possible differentials and make our approach align towards a definitive diagnosis. To support it, we can perform a quick physical examination and lab investigations. As in this case, we can check gait. A lot of information can be obtained by asking the patient to stand and walk without support. Proximal lower limb motor strength, rising from a chair. Gait can be categorized as wide-based ataxic gait, as in cerebellar lesion, hemiplegic gait, suggestive of stroke, and shuffling gait, as in Parkinson's syndrome. Romberg's sign, positive if patient stumbles forward on closing eyes. Balance requires sensory input from at least two sources, vision, vestibular and proprioception. If patient is bedbound, assess neurological system of lower limbs. Inspection, wasting, tone, ankle clonus, power, lift foot off the bed, coordination, run your heel up and down the sheen of your other leg, reflexes, knee jerk, and plantar jerks, postural dizziness, assess lying and standing blood pressure. If more than 20 mm of mercury, drop in systolic blood pressure, at 2 minutes, is significant. Now it's the time to tell the patient about the management part, including investigations and treatment. Regarding investigations, we have options of sepsis screen, urine, blood cultures and chest X-ray. If fall and altered conscious state, consider CT head. For any signs of subdural hematoma, especially in atrophic brain. Regarding treatment, we have plan of treat reversible causes, antibiotics, avoid polypharmacy, multidisciplinary team, case conference, involving nurse, social worker, occupational therapy and physiotherapy, need of stick frame, decisions regarding home improvements or residential care, resuscitation decision. Meanwhile, address the concerns of the patient. In the end, it's the time to close the case and talk to the examiner.